Welcome, everyone. Thank you for joining us to this new episode of the APMEN Exchange series. So last March 2020, APMEN held a session at an early stage in the COVID-19 pandemic, where we explored how countries in the Asia-Pacific region were going about sustaining malaria services despite the nascent health crisis of COVID-19. A year on, we're still very much dealing with the pandemic and rolling out our vaccination campaigns. We take stock today on the region's ongoing challenges and also its successes in keeping malaria under check. Today, we're really honored to hear back from Malaysia on their experience to date. As you know, Malaysia and Vanuatu, like many other countries in the region, are now rolling out their COVID-19 vaccination campaigns. And so for this reason, and due to the priority of this commitment, Dr. Wesley Donald from the Department of Health of Vanuatu will not be able to join us as planned for this discussion today. We do wish him and the Department of Health of Vanuatu much luck with this endeavor. This does mean that in this session, we will have more time following Malaysia's presentation for interactive discussion in the second half of this session. So before we get started, I just wanted to share a few words about the mechanics of the session itself. So if we could move on to the next slide, thank you. So first, you will have noticed we're in webinar mode, so your audio and video functions as participants is disabled, but we invite you to use the chat box to share comments, to also introduce yourselves, tell us where you're calling from. After Malaysia's presentation, please feel free to pose any questions to our presenter, Dr. Rose, through the Q&A box. You can also, on this Q&A box, upvote questions that you like from that are posted by colleagues on this call by clicking the thumbs up. In the second half of this hour, we'll have an interactive session where we will invite you to log on to a website called menti.com on your laptops or on your phones. And so please be ready to open a web browser page at that point. And once you reach the site, I will prompt you again. We will remind you of a passcode to join the interactive session, where we will have a series of online questions designed to hear from your experience around sustaining malaria interventions during COVID-19. After that, we will move on and end with a quick poll. So to lead us through this session, I'm very pleased to introduce our facilitator, Dr. James Kelly, who is Technical Officer for Malaria Surveillance and Elimination at the World Health Organization Western Pacific Regional Office. He's joining us today from Manila. So Dr. James Kelly, welcome, and the floor is yours. Thank you.
Thank you so much. Good afternoon, colleagues. Good morning, good evening, wherever you are. Thank you for participating in today's webinar. I'm very happy to be here today to facilitate this session on COVID and malaria. As Maria mentioned, I was fortunate to participate over a year ago in the initial APMEN X webinar exchange, where we discussed COVID and how malaria interventions can be sustained under the pandemic situation. So it's been a very challenging year for many of us in many ways, professionally and personally. So it's very interesting today to hear from the Malaysia Vector-Borne Disease Control Program. So our speaker today is Dr. Rose Nanimudin. She is the Deputy Director for Communicable Diseases, Disease Control Division at the MOH in Malaysia. She's also the chair of the APMEN Vector Control Working Group. Today, she will present on sustaining progress towards being malaria-free during the COVID pandemic. So Dr. Rose, it's a pleasure to have you with us, and the floor is yours. Over to you.
Thank you, Dr. James. Thank you very much. A very good day to all of the participants. I would like to thank APMEN for inviting Malaysia to share our experience in managing the malaria cases and elimination programs during the pandemic COVID-19 situations. I hope everybody will have a pleasant time during this webinar, and feel free to ask questions if there's any after my presentations. So I will share my slides. Sorry, I will share my slides. Right. So can you all see my slides?
Yes, we can see.
All right. Okay. Thank you. Okay. Today's topics is today discussions that I will share with the audience are how we sustain the progress, how we sustain the malaria elimination program during the COVID-19 pandemic. So these are about my presentation today. So I will share briefly on the COVID-19 situation and the chronology of the movement control order in Malaysia. And of course, the malaria trends during the COVID-19 pandemic, the critical actions that we have taken during this pandemic with the challenges that we have in the COVID-19 management, and of course the challenges and way forward of our program. So these are the COVID-19 status that is actually shared every day by our Director Generals of Health. This number, if you can see in the yellow color, is the new cases reported on the 8th of June, where we received about 5,566 cases reported in that on 8th June, and we have like 70 deaths in the red color reported on that day. So the cumulative cases that we already have in Malaysia is about more than 82,797 cases. So okay, so we started to have this pandemic, COVID-19 pandemic situation starting in March, even as early as I think 2020. And then our government implement the movement control order starting from March 2020. But however, the movement control order situations are changing from time to time, either movement control order or conditional movement control order or recovery movement control order or enhanced movement control order or targeted movement control order. So during this past 2 years, the movement control order status changed according to the COVID-19 cases reported in the country. And this is the number of cases reported, number of malaria cases reported, the overall cases reported in Malaysia. And if you can see that Malaysia actually has no indigenous human malaria reported since 2018. So we have a 0 human malaria indigenous cases reported since 2018. However, we still have P. nolosai cases reported, and of course imported human malaria reported in the country. During the challenges of the malaria service delivery during the COVID-19 pandemic situations, of course, the movement of control order limits the movement of our health staff for malaria service delivery, and also limit the movement of individual or community to access health services. And the MCO also interrupt the service delivery in the community because we were unable to enter the houses and we were unable to conduct certain activities, and we are not allowed to have a mass gathering, especially when we want to have a gathering with the community in terms of delivering health educations on malaria or any other diseases in the community. So and also we also have to mitigate the risk of COVID-19 infections among our vector staffs during their activities, and of course mitigation physiological destruction among health staff because of they having fear of being infected by COVID-19 or during, especially when they are doing this their activity. And apart from that, we also competing priority with other especially with COVID-19 management, and of course with other diseases in terms of competing the resources, getting the budget, and getting the logistic for malaria elimination program. And at the same time, there are certain situations that we have a shortage of PPE supply, especially during the initial phase of the COVID-19 pandemic situations. But however, this problem has been overcome by our government. And of course, because of the dynamic COVID-19 epidemiology and MCO instruction from the government, is because the instruction from the government always change based on the COVID-19 situation. So we as a service delivering, we also have to adopt with the instruction given by the government. And during, of course, I think not only Malaysia experiencing these situations, the potential impact of COVID-19 to our country progress towards malaria eliminations, of course, funding cuts, interruption in the supply chain of malaria commodities, and also a prolonged interruption of health services delivery. And this can cause actually reintroduction of malaria. And our way forward plans is to have a strong program leaderships at the national level. And this is very important for us because this will give us the guides and also give us advice if we are in the difficult situations. And critical intervention of malaria control must continue during the MCO. Later, I will share some of the activities that we still continue to carry out even during the COVID-19 pandemic. So disease burden stratification for malaria and COVID-19 are important to harmonize the critical interventions for both diseases. So there are some activities that we combine with the COVID-19 activity and also with malaria prevention activity, because for example, where the area that they implement enhanced movement control order, where our vector staff cannot enter this area, so we combine our activity with the COVID-19 teams. For effective planning, the program requires continuous updates of the COVID-19 situations. Example, the epidemiology, the mode of transmission, and of course, the situation of the MCO in that particular area. So in this case, we always communicate with our Crisis Preparedness Center of COVID-19, and we get the information from them in fact daily. And for effective implementations of critical interventions on the ground, health staff must be updated and convinced of the safety measures that implement in Ministry of Health. And of course, during the pandemic situations, we actually apply mostly our activity, especially in our surveillance program. We utilize the electronic and social media platforms for communications with even with the community and also with the state level and also with the district level. So malaria program must adapt to the new norm in the malaria control, especially when we carry out our malaria elimination control activities. And in the pandemic situation, the program must use innovative methods in delivery of service for malaria. How we practice our innovative measures in terms of continuing the vector control activities. We harmonized the malaria risk and the COVID-19 risk stratifications at the district level. So the district's health staff will assess the malaria risk and also the COVID-19 risk, and they will decide either the activity will be combined or can be done separately. So identifications of the critical actions for different level of malaria and COVID-19 risk is also done at the district level and state level. So at the national level, we monitor these situations. However, if the district and the state level having problem in identifying this level, they will consult the national level. So we also have to switch our control measures from IRS to LLIN for the control measure activity, for the vector control measure activity. And modifications of the LLIN distribution from mass distribution to house distribution is being applied, especially in the hotspot area of COVID-19 districts or area. So administrative order for critical action is also being given to the district level based on the COVID-19 pandemic situations. So these are one of the examples that we carry out during the pandemic situations. So we categorize, for example, the interventions and the activity. So we tailored intervention. So if, for example, the COVID area are in the green or yellow or red, this activity still can be carried out in their respective area. However, there are some activity, for example, SCD in RNA foci or SCD in cleared foci with high RV will be deferred. So this is how we categorize our intervention activities, and based on the zoning or the COVID-19 zone. So this one of the example, and this includes case management of outbreak, for example, for case detection, case management, and vector control activity, especially during the outbreak, must be carried out at all of the zone COVID-19 zone area. And for the entomological investigations, also need to be carried out at all the COVID-19 zone area. However, they need to follow with the certain standard operation procedures that has been given by our Ministry of Health. So this is also one of the example activities that has been carried out or deferred in certain area. So immediately when we had the movement control order instructions in March 2020, as early as April, second week of April, we already come out with instructions of what are the critical activities that need to be done, especially during if they have malaria cases reported or malaria outbreak reported in their areas. So in summary, because as the COVID-19 pandemic move from 2020 to 2021, we have so many different types of MCO. So if you can see in the blue color, we have like MCO, conditional MCO, recovery MCO, enhanced MCO, and targeted MCO. And all of this situation actually, we need to decide what are the activity that we can do, what are the activity that we cannot do at the district level, or either we have to do, for example, a meeting virtually, or we can do hybrid. We can have a small number of people attending meetings. So this is how we summarize. For example, in the MCO, the National Vector-Borne Disease Sector Technical Meeting will be done virtually. And however, the malaria case management will be carried out with the COVID-19 standard operation procedures. And even during the malaria outbreak, the SCD, the foci investigation, the vector control will still be carried out based according to the COVID-19 SOP. And the vector control activities still being carried out. The field supervision we do it virtually. Training also we do it virtually. And even during the World Malaria Day observance also we do virtually. So when we have enhanced MCO, for example, there are some activity that we will not be able to carry out. For example, doing vector control activities. So this need to be our activity need to be combined with the COVID-19 teams. So these are some of the pictures that that I would like to share. If you see, we have different types of MCO. So if you have enhanced MCO, you have the army to look after the area. Nobody can come in or go out from this area. So this is where our activity will be adjusted based on the situation in that area. So this is one of our example where we do our virtual or enhanced health education activity. We either we do through the Facebook, to the TV, or from radio, and of course we can also use from the Facebook. So I think that's all for my presentation today. I welcome any questions from the participant. Thank you very much.
Great, wonderful. Dr. Rose, thank you so much. Very interesting presentation. It's really nice to see how Malaysia has been managing malaria interventions despite dealing with the sometimes extensive COVID outbreaks. So I just want to pause and remind all participants, if you have any questions, please write them in the Q&A box. I would be grateful also if you could upvote. There's a little icon there. If you like the question, you can click and upvote. In the meantime, maybe I can start. Dr. Rose, you touched on several issues during the presentation. It was very interesting to see that the malaria cases, including imported cases, were quite lower throughout the year, especially during the movement control order. This seems expected as the population movement was more restricted. But also you were able to maintain 0 human malaria cases by tailoring these interventions in the COVID zones based on, standard procedures. This looks like a very well thought out and effective approach. So my question though is, how confident were you and the field workers about the stratification of the COVID zones? So the red, the yellow, the green, that this then allow the malaria interventions to proceed? Were there concerns about the possible transmission in the green zone, and how frequent would these zones be updated?
Yeah, we have in Malaysia, we have COVID-19 teams managing the COVID-19 outbreak or cases reported in the country. And at the same time, we follow their zoning. We do not create a new zone because this will create confusion to our staff at the ground, because some of our staff is also managing COVID-19 cases. If they have already implement their malaria activities, and in between they also involved in the COVID-19 activities. So for us, we do not have any difficulties in aligning the COVID-19 zone with the malaria control activity. But our instruction was all activity, some activity need to be done based on what I have mentioned in the table just now. There are some activity that they can do, and some activity they are not allowed to do because they cannot do like face-to-face or house to house. They cannot enter the house, but they can go to, for example, in that area and do for example, entomological surveillance survey or do just delivering the LLIN to the one house to house, but they are not allowed to have a gathering, for example. So this we adjust based on the COVID-19 situation. We have a COVID-19 operation center, so we usually follow on their announcement and their whatever instruction given from them, we follow, but we prioritize. That's why we have this either you can do or you cannot do. So we give the guide to the district to decide which are the activity they can do and they cannot do. And we have a surveillance monitoring. So we have a real-time web-based surveillance system, so we can see either if the activity is done or not. So this is we have access from the national level, the state level, and the district level. So it is not need for us to go to the ground to see if the activity is done, but we can see if they already do the activity. They will put in the system. They will report in the system. So this, even we can do daily monitoring of the activity from the national level, from the state level.
Okay, great, thank you. So we have another question here about malaria transmission. So also having to do with the MCO, meaning sort of tighter restrictions of travel within and between the states, including the people within the forest areas and the remote farm areas. Does this mean that there is less exposure and that human transmission of PK maybe cannot be sustained? And also that this may account for the decline of human malaria?
Yeah, basically, if the movement of population reduce, of course, not only for malaria, I think for all communicable diseases, trend also reduce because there are less contact, especially for communicable disease which involve direct contact or even with vector-borne diseases. So with the implementation of movement control order, generally is actually preventing people from moving from one area to area, and is also helping to limit the transmissions of all diseases, not only for vector, but especially for other diseases like tuberculosis, like measles, and all these things. And of course, that is a privilege for us in terms of controlling the disease. But the challenge is how the district need to identify what are the activity that essential they need to do. There are some activity that they might delay, but there are some activity that they need to do. That's why the critical activity they need to identify that one. For Malaysia, we have a privilege because all the health staff that has been identified by the district health office or by their center, we will give them a blanket approval for them to move from one area to area. So they have a sticker in their car that this is health staff that need, for example, a mobile health staff that need to move from one area to area. So we actually have the privilege that they can move from one area to another area, but only certain staff, not all staff, only staff that we recognize that need to do some activity. For example, the COVID-19 pandemic activities and also malaria, all the communicable diseases. We have stickers for them to move around in their vehicles.
That's very interesting. And as you may know, Dr. Rose, we also saw this phenomenon in the greater Mekong subregion, where during the travel restrictions, clearly transmission of diseases, including malaria, reduced because of because of just people staying at home more frequently and less travel and less risk of transmission. So that is also noted. But did you notice, if I may just add a question onto that about the testing levels in your country during the pandemic? Did you see the testing rates go down, or were they also sustained?
For malaria, you mean for malaria?
For malaria only,
yeah.
Yes.
Yeah.
Malaria.
If you notice, Dr. James, we still carry out the active case detection in the foci area. So if there are cases reported, they still need to do an active case detection. But of course, according to the COVID-19 SOP, so they still do the activity, which is we call the critical activity. So active case detection is in the foci still need to be done if the case reported. But of course, for example, doing bioassays, survey will be deferred in that area. But the critical activities still need to be done.
Yeah, testing and treatment.
Yeah.
Very good. Okay, we have another question here from the participants. Is there any evidence of person-to-person transmission of PK, P. nosai? And what is Malaysia doing to attempt control of PK?
Okay, thank you for the questions. Actually, the trend for P. nosai in our country is also reducing for these past few years. I think we had international discussions as far as in March 2017. If I'm not sure if you are involved, Dr. James, where we had in Kota Kinabalu, and most of from various countries, even from Harvard and from Oxford, researchers is also involved in these conversations. And we have a conference like 3 days, two nights and 3 days conference. And from that conference, we concluded that there is still no evidence of human-to-human transmissions of P. nosai in Malaysia. However, we did not stop at that level, but we still are carrying out a study with universities on still looking on if there's any evidence of human-to-human transmission. So it's ongoing at the moment.
Yes, that is interesting. Interesting discussion, and it is an ongoing story that's been ongoing for many, many years. So we know that as Malaysia approaches the certification missions and the national report and request to WHO for certification, We want to make sure that there is a control strategy for nosai malaria. So that is an important element of the vector-borne program. So that's good to hear that aspect. So there is another question here about why did Malaysia switch from IRS to Llions for vector control during the pandemic?
Yeah. Okay. For IRS, to implement IRS, we need to go inside the house and spray. So during the COVID-19 pandemic situations, if the government implement MCO, we are not allowed to go inside the house. So we need to switch. We need to do the control activity. So we just deliver the LLIN to the household, but without entering the house. So we just go and, okay, this is the nets that you need to use, and give the instruction, and it is less contact because we do not go inside the house, and we just deliver and give some advice and then move from there. And just to add in, Dr. James, actually for P. knowledge cases, we also come out with the guidelines of how to control the P. knowledge cases and also the P. knowledge outbreaks. So we already come out with certain guidelines for the district to follow if they have any cases reported in their area.
Very good. Okay, great. There is a question about malaria deaths here. So the country has been reporting several deaths over the last few years, even though there have been 0 indigenous human cases, human malaria. So are they from imported or PK or it wouldn't be PV or PF, but imported, and what species? And is there any reason for those deaths, if any, like delay in diagnosis or drug resistance, etc.?
Yeah, we reporting about, I think about five cases previously, but this is they were all from the PK non-lucide cases, and some we do have a mortality review for each of these cases when they are reported to Ministry of Health. And some of the contributing factor, of course, delay in seeking treatment. And of course, there also some shortfall, for example, miscommunications in the, for example, in delivering the treatment. So when we have this mortality review with the clinicians and the state level, we identify the shortfalls, and we will do the improvement immediately. So if there any, for example, delay in health seeking treatment, we will inform the mobile team in that area for them to enhance the activity, especially to the rural area, especially to the where we have where the area with high risk of infection. For example, a lot of imported cases happening in that area. So we will alert the mobile team to go more frequent and alert. If you have fever, please come to us. And we also have volunteers, for example, in Sabah, in the hotspot area. Previously, it was a hotspot area. We have these volunteers to do a blood smear in the community if they're having fever. So once they have fever, they will do the blood smear. So these are the volunteers that we already trained them for about, I think, more than 10 years. So they can do the blood smear immediately with the patients.
Yeah, certainly something that is challenging under the circumstances. So as a follow-up question, I see someone asking about entomological indicators. So for the validation under malaria elimination, what is Malaysia doing for its entomological indicators?
Well, we have this guideline. It's a
Yes.
book, but I just share some of the indicators that they are looking. Actually, it's a lot for for this, we have like we have these stratifications, and we have these indicators like vulnerability, receptivity, and even in the vulnerability we have like 10 indicators that we look into, especially for if this locality report any cases within 6 months, any cases reported, and of course for the malaria, for the vector, we have like okay, like type of premises, a species of vectors that they have in that area, as and of course type of water bodies, type of vegetations. These are being monitored closely in this area, and we have a lot of actually vector variables that we monitor. For example, human bite collection, animal bite collection, human bite trap net, and I don't know. There's a lot of methods being used in these guidelines. Of course, we do have that for entomological, and we have like more than 100 entomologists in the country who is actually monitoring the vector surveillance system.
Yes, Malaysia has been known to have such a very strong entomological surveillance network in the country, and that is a very strong component of your program. I'm wondering, just for the sake of sharing with others, it's in Malay, but I don't know if WHO has a version of that in English or if they're available. But it's something, your RV index and other means of measuring receptivity and vulnerability have been very useful for other countries to learn. So if there's anything you can share, maybe in links later that other countries could use, that would be helpful.
Yeah, sure. So I think there's a lot of like receptivities, like any vector found in that areas, biting time, parity rates, and density, all of these things, that a lot from
very comprehensive.
Yeah, which I need to learn, because I'm an epidemiologist, so I have to become an entomologist also to understand their surveillance systems.
Exactly. Me too. The same. But you, fortunately, you have very strong entomologists in your country, and that's very, very helpful.
Yeah.
Very good. Okay. Well, we have maybe time for maybe one more question. I don't see any more posted. Maybe I have a very brief question about how you've managed your virtual trainings. I know you've had to switch from training in the field to virtual. How have you managed that as a program?
Yeah, very challenging because in a virtual training, they sometimes they log in, they have their names there, and then they close the camera, they close the microphone. You don't know if they are really exist in that. But however, we need to sometimes we do like pre-test questions and post-test questions during the training. So this is just to ensure that these participants are actually following your lecture. So we give lecture, mostly we have to adjust, even though the practical to the theory. So this is a very challenging, especially during especially if you want to do entomological surveillance methodology. So this is, you need to adjust that to more to theoretical. But however, the most important is for them to know what are the indicators or the methods that they can use, and if they have any questions, we are contactable by WhatsApp or by call anytime. So we also have a WhatsApp group in the technical group, so that if any questions, they just can throw in the WhatsApp and we can discuss and we can have a video call and just to show them how it's being done. So
very good. Yeah, okay, that's good to know, and I think that could help other countries and WHO to manage some of these virtual trainings we're having to do. One more question came through about needing to do entomological surveillance in malaria-free areas. can you speak to that? Are you continuing? I know WHO has a perspective, but what is Malaysia doing for entomological surveillance where there is zero malaria? You're continuing it.
Yeah, we because some of our area previously was a red area. So, but when after many years, when they reach the eliminations, they become green. So even this green might not, they still have a risk of transmission. For example, vulnerability, they still are foreign workers going there. They might not be tested. They might have been carrying the parasite with them. And there are certain area, even though there's no cases happen in that area, but they still have this vector around. So we still need to do the assessment, entomological assessment. And once we have a score for that, we combine the vulnerability indicators and the receptivity indicators, and we can have a score. So if the score is too high, means that the risk of infection is very high in that area. So this is where we have to intervene immediately, because we have like thousands of area which previously might be red, but now is already have become green. So, but there are areas which are very high risk. So we use this scoring to prioritize where are the activity need to be done immediately and following the priority of the scoring. So otherwise, our staff cannot cope with the high. If they want to do everywhere the monitoring, they might not be. We don't have the resources to cover all area, especially during the COVID-19. So we have to prioritize which are the area with high risk and not.
You take into account the imported, where in the country the imported cases are going or coming from, not coming from, but where they end up in the country. You weigh that, you weigh the index based on importation?
Yes, of course, Dr. James, because in the vulnerability means if there's any risk of foreign workers or illegal foreign workers coming to the area, even though it's MCO, you know, the border is very porous. I mean, people still can come in and come out during the MCO. I don't know how it's happened, but it is happening. It is happening. So we have to accept the fact. And this is for vulnerability. And for example, for receptivity, of course, we look at the vectors that they have in that area. So these factors, receptivity and vulnerability, we combine to have a score of the risk of transmissions. So this is very complex, but it is manageable in our level. I think other countries also can do. They can choose which are the minimum indicators they can use based on the system they have, and identify which are the area with very high risk of transmissions, and prioritize the activity to this high risk area.
Okay. Where do you see most imported cases?
Sorry?
Which provinces are you showing most imported cases?
Well, our challenge is mainly at the Borneo, especially in Sabah and Sarawak, because of the border between, between other countries like Kalimantan and also area where, and also in West Malaysia, especially border with other countries like Thailand. So this is the very challenging area for us.
Yes, yes. Very good. Well, thank you so much. I think that concludes the Q&A session. Thank you so much, Dr. Rose. It's very interesting to learn from you and all of your experience on your road to elimination. And it's very encouraging to see you sustain 0 indigenous human cases. Also in the COVID situation, it's quite a challenge, but it's been very interesting to learn from you and hear your experience. So with that, I think we'll move on to the next session for the interactive discussion, and I'll turn it back over to Maria for explaining that. Thank you, Dr. Rose.
Thank you. Thank you.
Thank you, Dr. Rose, and thank you, Dr. James, as well. So we'll now move on to our interactive session. I'd like to invite you all to open your web browsers to a new page, so that can be on your computers, on your laptops, or on your phones, whatever works. You can type in and go to the website called www.menti.com. That's MENTI.com. Once you reach the website, you'll be prompted to enter a passcode, and that passcode is 47985971. I'll repeat that in a moment, but just to let you know, the link to the web page and the passcode will be pasted into the chat box by my colleague as well, so you can refer to that. But once you reach menti.com, MENTI.com, you can enter the passcode 47985971. There you'll have access to a series of questions, and we'll go through them together one by one. You can input your answers live on there. It's all anonymous, but when you submit your answers, you can, of course, indicate in brackets, if you wish, which country you're writing from, submitting your response from. That's entirely up to you. So what I will do is I'll screen share and lead you through the presentation. Dr. James Kelly will guide us through the different questions one by one and the answers that come through. So I will screen share now, if you just bear with me 1 second. And now that we're ready to go, I will hand it over to you again, James. You have the name of the website again on top of your screen here and the passcode. So hopefully you can all access the website okay. All right, thank you.
Okay. Okay, let's see how this goes. I've not tried this before, so it will be interesting. I hope you've had enough time to log in with the passcode, which are in the chat. The purpose really is to hear from all of you who are participating in the region or other places about what successes or challenges you've been experiencing. So the first question here, what is the greatest health system challenge posed by COVID-19? We'll give a few minutes for people to log in and respond. Disaster, yes. Maybe other people are still logging in. Oh, here they come. Okay. Devastating, yes. Shifting interests, less money for malaria. I think a lot of countries have experienced repurposing of staff, of course, for shifting from malaria to support COVID activities. Regress. Yes. Shifting priorities. Online meetings. Yes, I think we can all relate to online meetings and travel restrictions. Burnout. Yeah. Yes, priority changes. Unprepared. Isolation. So I see some personal responses in addition to health system impact. Collapsing. Frustration. Worry. Yeah. Some of these are repeating, shift to virtual. But I think overall we're seeing some similarities with responses around strains on the health systems and repurposing of staff and shifting from malaria specific to more COVID response and people feeling overwhelmed and burdened and isolated. So yeah, it's very good, very interesting. So by the way, all of these responses are being saved in the background. I think APMEN is managing this, and there may be a chance to publish in the future a summary of some of these responses that would be helpful for all of us. Okay, let's move on to the next question. So maybe just a bit of a background. From the WHO side, in 2020, WHO launched what was known as the Pulse Survey. This survey reached out to countries and member states to try to understand some bottlenecks in malaria services that might be happening, as well as affecting essential health services during the pandemic. Not only WHO, but Global Fund and Malaria Consortium and other partners, many partners have reached out to countries and tried to investigate possible bottlenecks of implementing malaria interventions during the pandemic. I think in summary, results of these surveys really demonstrated since 2020 that some malaria services, such as diagnosis and treatment, really fell short of normal across the region. In some cases, they fell dramatically. Globally, I think over a third, some of the data showed about a third of malaria endemic countries that reported in the Pulse survey had a disruption of vector control campaigns, including Llions and IRS. So with this in mind, what are your thoughts? Write down your thoughts, whether it's affected, somewhat affected, or not affected, about COVID affecting malaria interventions in your country. So most responses are clearly showing somewhat affected, and around the same number were severely as did not affect. So I guess the message here is that depending on this, maybe the strength of the health system to begin the pandemic versus health systems that were more strained, or malaria programs that had in place parameters that allowed them to continue their services. So I think in general, somewhat affected, yeah, looks to be the majority. Next question, please. Okay, share some examples of successful adaptation methods or adaptation methods to sustain malaria services during COVID. How has your program or country or organization adapted to sustain services, malaria services during the pandemic? We heard from Dr. Rose, they've had to switch to door-to-door distribution of bed nets and virtual communications, indeed. Communication through radio and TV. Prioritize activities, depends on the risk. We saw a very good stratification agenda in Malaysia. Online meetings, yes, WhatsApp reporting. Rely on more community delivered models. That's very interesting. I'd love to hear more about that and how programs or organizations have actually implemented community strengthening for delivering interventions. I think that could be used in the future, even in the context without a pandemic. Strengthening communities is very important. Changing control measures from IRS to LLI in-house distribution. Integration of programs, we've seen a lot of that. Struggling to roll out activities, okay. I'm seeing several community-based models come up. That's good to see. Strengthening malaria staff. Mobile clinics. Community health workers doing COVID and malaria. Yes, struggling to roll out. Yeah. LF2, F2F. What is that one? Okay, good. Very good. Okay. Yeah, we see quite a number of things coming up here. Next slide, please. What support does your country or organization need to strengthen health systems and ensure progress towards elimination? Yeah, financial resources is the first one that comes to mind. Training young entomologists, yes, mentoring and training younger generation. Okay, I see a plug from Cambodia. That's good. Hopefully they can eliminate PF by 23. I think it's possible, certainly. They've shown very good progress in Cambodia. Surveillance system upgrading. Indeed. I think that surveillance system integration is also, we're seeing that in countries. Multi-sectoral support. It's interesting to see that all sectors are not talking with each other. That's the reality on the ground. We would like to think everyone's collaborating, but in some cases that's not happening. Advocacy for political commitment. Very good, yeah. Ownership of the program by stakeholders. Yeah, additional training and capacity building, particularly of entomologists. Integrated management, yeah, very good. Yeah, so these answers are very acute and aware. I think this is something that these have come up for not just the pandemic. I think these are also important just to consider about strengthening the health system and strengthening the malaria progress to achieve malaria elimination overall. Very good, interesting to see. Okay, next slide. So plugging again the WHO Pulse survey, there was a second survey, a second round released in April this year. I think there's a link in the chat box over there. And this survey results showed that health systems are indeed being tested more than after a year in the pandemic. This was done in April of 21. And nearly all responding countries reported at least one service disruption, and disruptions were reported across all health areas. It really demonstrates a far-reaching impact of the pandemic on health systems. So in terms of your thought, the Pulse survey reported that health workforce related disruptions occurred in almost 66% of countries. Does this affect your country? So disruptions to the workforce, has it disrupted, particularly for malaria service? Yeah, majority are yes. So that hasn't changed much since the survey was done. Okay, good. Next question, please. What measures would you recommend or need to remove barriers to access care and to empower health workers in your country? What measures would you recommend or need to remove barriers to access to care and to empower health workers in your country? I can think of distribution of PPE, vaccinations, of course, yes. I think Dr. Rose mentioned one about exemptions for movement of health staff, giving them a pass to travel between districts. Access to training, rapport building and working on myths and misconceptions, exactly. So reduce fear of seeking care with the communities and the health staff. Yeah, let the communities and health workers be represented well. Upskilling. Yeah, consideration for staff to conduct and continue surveillance. Yeah, I think this was well thought through as identified by Malaysia in their stratification of areas where where active case detection and other interventions could continue based on the stratification of COVID. I think that helps think through the identification of some of these bottlenecks and what might be needed. I don't see PPE, but that's also been discussed and recommended by WHO. Okay, next question, please. Supply chain. So supply chain disruptions were a concern in 29% of those countries surveyed in the Pulse survey. Did COVID affect access to malaria commodities in your country? And we have here either diagnostic tests or treatments or vector control tools and interventions. Did COVID affect vector control interventions, malaria treatments, or diagnosis? And it's just yes or no. You can see that adjusting as you enter your result. Yeah, I think it's interesting to see that some countries were affected and some were not for various commodities. I know there are a number of factors that go into this, including the manufacturing delays. WHO has noted that some production and manufacturing of diagnostic tests were repurposed. Some companies decided to pause on their malaria RDTs in order to make COVID tests. We saw that ACT disruptions were less, although there were talks when some political figures in countries were promoting anti-malarial drugs for COVID treatment, that there was concern and there was a potential disruption of malaria treatment productions for malaria in place of COVID. And I think for vector control, bed nets production have continued. Of course, so many bed nets are produced in India, and the devastation that's happened in India over the past year has really did have an effect on the production of Llions and the manufacturing, but I think this may not be seen yet but it might still be a lingering effect in the coming months. We'll wait and see as countries order their global fund distribution, mass distribution nets. Okay, next, final question here. What have been the main surveillance and reporting challenges in your country? We've made this a multiple choice, but not everything's covered. Real-time data reporting, has that been a challenge? Accuracy of data, notifiable disease systems, or reporting from the private sector? Interesting to see private sector. Yeah. I would have thought real-time data reporting might have been affected as well. It seems to be as important or as affected as the private sector. Accuracy of data in some cases has been a challenge. Yeah, there's the real-time data catching up. Very interesting to see. Okay, everyone. Well, this has been interesting. Mentimeter, so something we can learn every day. It's interesting to see the new tools we have available for us for information gathering. So it's been very interesting to facilitate this session. I'm happy to have joined, and I really enjoyed. Thanks again to Dr. Rose for her very interesting presentation. And with that, I will turn it back over to Dr. Marie for closing remarks. Over to you. Thank you.
Thank you, James. And also thank you to all of you for participating so actively in our interactive session. It was really great to see your responses flooding in onto the screen there, and definitely very interesting to have all of that information in hand now. So just a few words to conclude. Today, we explored how, in the case of Malaysia, a near elimination country, how one country managed to sustain 0 indigenous cases despite the health crisis of COVID-19. There's a lot that we can learn from Malaysia's experience and other countries' experience in adapting malaria interventions to the pandemic situation and all the challenges that come with that. So reflecting on Dr. Rose's presentation and also the rich inputs that were received through the interactive session, I noted three main points that I thought I'd try to sum up. And so the first one that stood out to me, that came out in a few of the responses on Mentimeter, was around sustained leadership and political commitment. And I think the caveat with that is that it also has to trickle down all the way to the community level, and that the role of communities is absolutely critical to sustain these interventions and continue progress. More than ever, we need leaders back up to, for example, arrange for special movement control orders, like we've seen in the case of Malaysia, provide derogations so that services can continue. Commitment to equipping malaria health workers with the right personal protective equipment, and also enabling entomologists to continue doing their surveillance work to keep the surveillance up and going. So sustained leadership and political commitment being one to back it all up. Linked to that, as a second point that also came out in a lot of your responses, and Dr. Rose mentioned it, is sustained financing for elimination. So for malaria elimination, and then obviously sustained financing to continue strengthen health systems at large. And that's about budgets, financing for health. The pandemic is inevitably going to have huge economic impacts globally. We haven't seen the magnitude of that yet, it's too soon to tell. But we should all as a community, including APMEN and APMEN, continue to advocate for government and external funders to sustain investments in malaria. We've also seen how investing in malaria in a community health workforce has also helped to tackle the pandemic, particularly in the more remote and hard-to-reach areas, by improving access to basic health services there. So that's a very critical point in my view, and I think many of you share that perspective as well. And then as a third point, I just wanted to mention 3 I's that popped up in the discussion today: the I of information, the I of innovation, and the I of integration. It's clear that data really shapes and targets all health interventions. We've seen how it's possible to gather real-time data for COVID-19 through standardized reporting, standardized dashboards at a global level. We should be able to do the same for malaria in real time. So as we approach elimination, as we better target our surveillance systems, improve surveillance at subnational level, making malaria notifiable means we can ensure that we catch every last case. So with that, we need to keep up active surveillance for malaria even during COVID-19 or another health crisis. We need to adapt also, and we need to innovate. For example, Dr. Rose shared Malaysia's experience in using social media as a means of communication. We need to change up our strategies and adapt them by zone, like Dr. Rose explained, by risk zone. And eventually, as we move forward, to also integrate malaria surveillance and response within the broader health system. We heard also from Dr. Rose about the value of integrating the malaria response with the COVID-19 response. So tracking and tracing of fevers on the ground for both diagnosing malaria cases and or COVID-19 cases as well. So these are just very general observations and a mere attempt to summarize the rich discussions from today. Again, a huge thank you to all of you. I do want to mention that indeed the responses that were shared today, we have them saved. We will look at them again. We will reflect on those, particularly as we embark on the development of a white paper on COVID-19 and malaria in Asia Pacific. In this white paper, we'll endeavor to capture some of the best practices from countries in the Asia Pacific region on how they have dealt with COVID-19 and sustained their malaria responses, and what challenges countries have faced as well. So we really look forward to being in touch with you about all of this. So please feel free to reach out to us for feedback on this session in general or on anything else, or to share with us how we as APMEN might be able to help you further, how the WHO can continue to support you in your efforts as well. And before we end the webinar, I just want to mention that you will see popping up on your screens a quick poll just to get your immediate feedback on this session and see how we can improve it. So if I may ask of you for an additional few minutes to just give us your feedback, that would be most grateful. And with that, just giving you time to share your responses, I want to thank once again our panelist, Dr. Rose, and our facilitator, Dr. James, for your time today, for leading us through the discussion, and of course all the participants for being so actively involved as well. So thanks everyone. Wishing you all the best. Thank you for joining, and have a good rest of the week.